Hey, good afternoon. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center. Thanks for joining me for Facebook Live today. So we're going to do a couple things. I'm going to do a brief COVID update, just giving you some latest information. And then I'm really looking forward to our conversation with Dr. Ajay Buddaraju, who is the rheumatologist here at CGH. And he does a really good job. And there's a lot of conditions that I think you're going to find interesting to have him give some answers to. So as always, as I'm going through what I'm talking about and I'm asking questions with Dr. Buddaraju, please feel free to send your questions to us and we'll try our best to answer them. With that being said, let's talk a little COVID. So I think the things I just want to highlight is what we're seeing, kind of the trend is this Delta variant, which I think it kind of comes from India. It was about 1% last time I looked, and today I was looking, and it looks like our percentage of cases in the US is about 6% that are from that variant. So it's definitely growing. And the thing about that variant that's different is it's about 40% more contagious than the UK one that's pretty predominant right now. So it's just more contagious. The Pfizer is about 88% effective versus I think it's 91 to 93% for the other variants that you throw in there. It still does, the vaccines still do a really good job, even for the one, this Delta variant, as far as we know, in preventing severe disease, that's really what you're after in a vaccine. It's nice if it just stops disease altogether, but just not getting so sick that you have to go to the hospital or have any long-term health repercussions from it is the best thing that you can get out of. I mean, it's not the best thing, but it's at the end of the day, that's the really good thing that any vaccine can offer like this is really good. So once again, I think the key is to continue to think about getting vaccinated. And I saw today in the state of Illinois, actually it was yesterday, I think 68% of Illinoisans had at least one vaccine, and 51% of us were fully vaccinated. If you take the 68% that have had at least one vaccine, we know that right now about the effectiveness of the Pfizer shot, for instance, and Moderna is about 80% if you've had that one shot. So that helps, and then you get everyone fully vaccinated and they get more up in that 90% range. And then on top of that, you have people who've already had the infection. That's why we see our numbers so much better. That's why they're improving so much. And I know Matt, I sent these numbers to Matt just now. I don't know if Matt has them ready or not, but thanks, Matt. So you look at those numbers and it's kind of how it's been trending, and it's really encouraging. The right side here, you'll see the cases this week is red and previous week is blue. And every time that we have been showing you that this week is less than the previous week, good thing. And the positivity rate is 0.8%. And the number of cases is relatively very small. So good stuff as far as that goes. Thanks, Matt. I think there's another thing I want to highlight about is not so much COVID, but the repercussions of COVID. I was just reading today that death from diabetes and heart disease is up quite a bit since the pandemic started. As a matter of fact, greater increase this past year than the previous, I think it was 20 years ago when it was this much of an increase. So I think folks are avoiding care when they have symptoms, and I would just, particularly now as things are much more winding down in terms of the number of infections, I would really encourage folks that are listening or folks that you know in your life who have any sort of concerning symptoms or are putting off taking care of their chronic health issues to beginning re-engaging with the medical establishment to take care of those problems, because we are seeing the indirect side effect of this pandemic in terms of the number of people that are dying from their chronic problems and or symptoms that they're having. So please keep that in mind. Keep in mind too that we're just talking about relative risk here when we're talking about getting a vaccine. you take a risk when you drive a car, when you walk down the street, when you get on a bicycle. I mean, even some of the medicines you take, a lot of us take something called like Prilosec. You probably heard of that one, Nexium, Pantoprazole, or Protonix. Those medicines are called PPIs. They're very helpful for people that have reflux disease or heartburn. 20 people out of 100,000 that take those have issues with their kidneys. And people take them all the time and do just fine. We have to watch people's kidneys to make sure that they do okay, but there's a relative risk there. I think the relative risk of getting this vaccine is far less than that, actually. So anyhow, just to give us some perspective on the vaccines and their effectiveness and their safety, I would really encourage folks to continue to get those. We're still giving some vaccines. I think we gave 211 this week here at through the hospital. But the number of people that need to get them or willing to get them is definitely going down. So I encourage you to go wherever you might need to go to get those done. All the retail pharmacies in the area and the health department are also giving vaccines. Our vaccine clinic now is from 8:30 to 2:30, Monday through Friday at the main clinic. And one other thing just to keep in mind is, a lot of people are immunocompromised and they got the vaccine, but the vaccine probably won't work real well for them. And so that's another reason for those of us whose immune systems work well to get vaccinated, because it helps to protect those other folks who, even though they did the right thing and got vaccinated, they're still not fully protected. Okay, that's my COVID thoughts for this week. As always, send me questions if you have any questions about those. But I want to get to Dr. Buddaraju, and let's talk a little rheumatology. So Matt, can you bring in Dr. Buddaraju? Hey, hi, Dr. Buddaraju.
Hi, Bill. How are you?
I'm doing well. Thanks for joining us. Dr. Buddaraju,
wonderful opportunity to get in touch with the audience and to talk to people.
Yeah.
To provide some insights into what we do here at the clinic.
Yeah. So and just for the folks who as they hear this conversation, might be interested and realize that they need to see Dr. Buddaraju. He splits his time between Sterling and then our Dixon offices. I think you're in Dixon today, aren't you?
Yes, I'm in Dixon today. Yes.
Yeah. So, okay. So let's get to it, because we have a lot of questions to go through, a lot of things that I think folks will find interesting. You ready?
Yes, I'm ready. Please.
Okay. First question. One of the most common diagnoses I think you probably see is rheumatoid arthritis. So tell us a little bit about what causes rheumatoid arthritis.
So our understanding of the rheumatoid arthritis has evolved over the years. And we do have a much better understanding why and how people get rheumatoid arthritis. But are we there yet? No. We still don't know exactly what triggers rheumatoid arthritis in patients. But at least from our understanding, it is a complex interplay of genetic factors and environmental factors. So the genetic factors, like in people who are born with certain set of genes, especially genes that are linked to what we call as a HLA, and environmental factors can be anything. It can be like smoking is one of the obvious risk factors, and it increases the risk of rheumatoid arthritis, and it decreases the effectiveness of medications you use for the treatment of rheumatoid arthritis. And there is definitely some studies that suggest the role of infections, how and what kind of infections, no one knows exactly. And then there is definitely a role of hormones, because rheumatoid arthritis is much more common in females than males. So there is definitely a role of hormones in either why some people get it and why some people don't get it.
Okay, yeah. Okay, next question then is, sounds like we have some idea but don't know for sure about all that. Next question is, so if someone has rheumatoid arthritis, what type of symptoms do they typically have?
So first, let's step back a little bit and let's just talk about what rheumatoid arthritis is. I mean, contrary to what it says in the name, everyone thinks that it is an arthritic condition. Yes, it is an arthritic condition in majority of the patients. So they usually present with the joint symptoms, like either it could be pain, it could be stiffness, it could be swelling. But in a small number of patients, they can present with some atypical symptoms. So people can present with involvement of the lungs. So people can have like a fluid around the lungs, so they can present with either chest pain or shortness of breath. And I have seen patients that can present with fluid buildup around the heart, so they can present with like the chest pain and the shortness of breath. But in majority of the patients, it is the involvement of the joints, and usually it starts out in the small joints of the hands and in the wrists, in the feet. And then other common joints are like you can have it involving the knees, elbows, and shoulders and stuff. But there are some joints that are less prone to get rheumatoid arthritis, and usually it is the axial skeleton, so which is basically the spine. So we, especially the lower back, is a very uncommon area to get rheumatoid arthritis. You can get rheumatoid arthritis in the neck, especially in patients who have like long-standing disease and who have like an uncontrolled disease. But usually the common symptom is usually the pain, stiffness, and the swelling. But usually it starts out in the small joints of the hands, and it's usually like a symmetrical presentation. What I mean is basically you have involvement on both sides of the body. So if you have symptoms in the hands, it's usually on both the sides. It doesn't necessarily have to be in the same joint on both the sides. So if you have involvement of the one knuckle on the right hand, it can be involvement of a different knuckle on the other side. But what I mean is basically it usually involves both the sides.
Okay. Would you hold your hand up and just kind of show what typically are the joints in your hand that you would see rheumatoid arthritis versus like what we call osteoarthritis?
Yeah, sure, absolutely. Yeah. So usually with them, if you look at my left hand,
yeah, I got it.
Usually when you have rheumatoid arthritis, it's usually these joints, so what we call as the MCP joints and metacarpophalangeal joints of the knuckles. And you can also have involvement of these joints, which are the proximal interphalangeal joints. And versus usually in patients with osteoarthritis, you typically have involvement of the tips of the fingers, usually what we call as the DIP joints. You can have involvement of the DIP joints with osteoarthritis, but in patients with rheumatoid arthritis, it almost never affects the tips of the fingers.
Okay. Yeah, that's a good differentiator, I think. So like I've always been told and always kind of thought of that, boy, if I found out that a patient of mine has this, I want to get them to you as soon as possible and get early treatment going. Is that correct? And if so, why is that?
Yes, it's very important. I think one of the things that can improve the outcomes is early intervention in patients with rheumatoid arthritis. The reason being is even with all the research, all the medications we have right now, unfortunately, there is no cure for rheumatoid arthritis. So anything you do, you're basically trying to get the disease under control, keep the disease in remission. So in patients with rheumatoid arthritis, when you have this inflammation in the joints, and if you don't act early and aggressively, what happens is it can destroy the joint. It can destroy the joint, it can destroy the cartilage, it can destroy the tendons, and it can lead to significant deformities in there, and obviously it can affect the quality of life. And unfortunately, once the joint is damaged, no matter what medication you use, you can't bring the joints back to normal. So that's the reason the key is early intervention and regular follow-up, and that's what's going to help you. But with the medications we have right now, I mean, you see patients with rheumatoid arthritis and you don't even think that they have rheumatoid arthritis because they respond so well to the medications. Yeah. And the joints almost look like a normal hand.
Yeah. You want to talk about those new medicines a little bit? I take it that's kind of been since even your career started that those have been.
Yes. I mean, majority of the new medications that come out or that are going to come out they fall under what we call as a biological DMARDs. DMARDs are basically these medications which can modify the disease activity, so which play a certain role in controlling these abnormal chemicals that can destroy the joints. So one of the first drugs that were approved in this category are what we call as an anti-TNF therapy, basically anti-tumor necrosis factor therapies. There is like a lot of medications in these, But if you look at one of the first ones that's approved is what we call as etanercept or Enbrel. And the second one that was approved is adalimumab or Humira.
Yeah.
And there is like a few other medications in this category. These are usually given as injections. And then you have like a second category of medications like the Orencia, which acts like in a different way compared to the first class of medications. And this is also given as an injection. And when you have the latest medications, the good news is these are like you have what we call as a JAK inhibitors, and basically like Janus kinase inhibitors. These are like small molecules that play a role in the inflammation. So these newer medications, they can be given as oral medications. So the three medications that are approved so far, the first one is what we call as the tofacitinib or Xelzange. And the second one that's approved is Olumiant or baricitinib. And the latest one that's approved is Rinvoq, or what they call as Upadis.
Yeah.
I think I got that right.
Oral medicine, that to be able to take something by mouth and take it at home, that's going to be a really nice thing.
Yeah, there's going to be game changes, but unfortunately, like what happens is there is no easy way of predicting which class of medications works for the patient so far. There have been like studies that doing genetic studies to see if you can tell, like, so as soon as you diagnose a patient with rheumatoid arthritis, you do a certain test and find out like what medication works for you, so that you don't have to go through medications like a trial and error, which is how we do it. Like the same thing like how you do in patients with high blood pressure or how you do with diabetes. Unfortunately, there is no easy way of knowing how the patient responds to it, if the patient is going to have any side effects of the medication, how they're going to tolerate to that, and how they're going to respond to that. And I think things are going to change. I think they're trying to do genetic studies to see if they can find out, maybe looking at a patient's joint to see what kind of abnormalities they have in there and see like how like which medication they're going to get the best response out of with minimal side effects. I think that would be awesome. So that would be awesome. Then you can have these targeted therapies that are individualized to you versus kind of like a generalized, you put it everyone with rheumatoid arthritis under one umbrella and just start throwing at medications to see like which one works for you.
What are the main in these class of medicines? What are the big side effects that folks have to be aware of?
Yeah, so again, I think it depends on which medication you're taking. But in general, like overall as a class, is what we call as these biological therapies. The common side effect everyone worries about is the risk of infection. So the rheumatoid arthritis is an immune-mediated condition. So any medications you use, they can affect the immunity. So I mean, immunity is good for you. That's how your body protects against like an infection, cancer, and something like that. But at the same time, in these people, you have this immunity that attacks your own joints. So you have these immune cells that are attacking your own joints. So when you use these medications to suppress these immune cells, obviously there is a risk of infection. That's one thing. And the other thing that everyone worries about is the risk of cancer. The risk is minimal, but the risk is there. Risk of malignancy. Like, I mean, the common cancers that you worry about. I mean, rheumatoid arthritis itself can increase the risk of cancer, like lymphoma. It can increase the risk of lymphoma. But these medications, some of these biological agents, yes, they can also increase the risk of lymphoma. They can also increase the risk of certain skin cancers. So these are the things you look into in patients who have these, a prior history of that, then you try to find the best option for them.
Yeah.
And in some of the other medications, you need to monitor their blood counts because they can affect their white count, or they can affect their hemoglobin. And in some medications, you need to monitor their liver tests just to make sure they're not getting any side effects from the medications.
Yeah.
But overall, as a class, I think these are relatively safe medications. Most of the patients, they do really well on these medications. And obviously, you have a certain percentage of patients that don't do as well. And then you move on and try something else that works better for them.
What are you telling your patients that have gotten a COVID vaccine, who are on these kind of medications? What is your what's your message, your advice to them? What's it been?
So in general, rheumatoid arthritis itself, I'm talking about rheumatoid arthritis, not taking any medications. It itself confers the risk of infection. So compared to like general population, people with rheumatoid arthritis, there is an increased risk of infections. So as we talked earlier, because it is an immune-mediated disease, obviously the risk of infections is higher, especially when you're taking certain medications that can lower the immunity. Having said that, I definitely and we definitely recommend people to take the vaccines. The reason being is one is it reduces the risk of infections, and some of the medications, like depending on which vaccine you're taking. So if you're taking like a live vaccine, obviously you can't take it when you're taking some of these medications, especially the biological. But if you're taking like an inactivated vaccine, like this COVID vaccine, and you can take it even when you're taking these medications. I mean, certain medications we try to tell them to space it out. Like say if we have a class of medications called as B cell therapies that basically affect the B cells which produce the antibodies in the body, like rituximab. In those medications, if the patient is on that medication or if the patient is planning to start that medication, what we tell them is we tell them to try to get the vaccine before, and then depending after wait for a certain time, and then start you on that particular medication. But with other medications like say Emerald or Humira, you can take the inactivated vaccines even when you're on these medications. Is there a concern that you might not get as much response to the vaccine compared to like someone who is healthy, not taking any of these medications? Yes, absolutely. I think the amount of immunity this vaccine generates might not be as high as someone who is not taking these medications. But at the same time, I think the amount of immunity that's generated is protective against the virus. So yeah, absolutely. We recommend even people taking immunosuppressive medications to be on the vaccines. And it is all the more reason for those people who are taking immunosuppressive medications to actually take the vaccine.
Yeah, good. I said there's a question that came across the screen here. Would you put that back up, Matt, for Dr. Buddaraju? I have recently been diagnosed with RA and am ANA positive. What are my next steps and what will I learn at my next doctor visit?
Okay. I mean, ANA is basically like what it stands for is an anti-nuclear antibody. It is like an autoantibody, and usually you see it in a lot of autoimmune diseases. But again, it's not a specific blood test. You can see it in patients with lupus. You can see it in patients with rheumatoid arthritis. So if you are diagnosed with rheumatoid arthritis, the first thing is definitely you need to see a rheumatologist, so at least they can evaluate you first and see where your disease is, if it is like a mild disease, if it is a moderate disease, depending on how many joints are affected, how severely it's affecting you, and if it is affecting any other areas. As we talked about initially, because rheumatoid arthritis can affect other organs, although most of the patients, they usually present with joint symptoms. So the treatment depends on how severe the illness is. And the important thing is stressing that trying to start the treatment early on, it improves the outcomes, and you can have like a normal, good quality of life.
Ajay, let me throw this out and kind of follow up to that viewer's question. Can you have a positive ANA and not have a rheumatological disease?
Oh, absolutely, absolutely. I think actually, if you look at the overall, if you look at the studies and if you look at the number of patients that have a positive ANA, I think you can easily say that close to 80% of the patients might not have an underlying rheumatological condition.
What percentage was that again?
I would say like close to 70 to 80% of the people that might not have an underlying rheumatological condition. Okay. So the reason being is especially depending on how you look at it, because I mean, it can be variable. So this one I'm throwing it out, especially in patients who have like a low titer ANA, because they give you titers on how significant the ANA is.
Yeah.
But apart from the rheumatological diseases, I mean, it's not a specific blood test. I mean, it is a sensitive blood test. Like in patients with lupus, about 90% of the patients have a positive AMA. So you can almost say that it's a very rare thing to have lupus with a negative AMA. But the other is not true, that the vice versa is not true. Um, because in majority of the patients with the ANA, there is a lot of other reasons that can cause ANA. Obviously, there are other rheumatological conditions that can cause it. Medications is a common thing. Some of the medications people take, like some of the medications people take for blood pressure, some of the medications they take for the treatment of seizures, some of the medications actually you take for the treatment of rheumatoid arthritis and stuff. So they can trigger a positive AMA. And infections is a common thing because infection can trigger the immunity, and sometimes they can also generate autoantibodies like an AMA.
Right.
And as you age, it's a common thing to see. I think it's how the immunity evolves over time. You can see like more and more autoantibodies, even in normal, healthy individuals.
Yeah. You know, another I bring up too, just because I think in my practice, you know, people can have sometimes some vague symptoms.
Yes.
And, you know, they don't have the swollen hand joints, and they have some vague symptoms that you wonder about. Maybe they're stiff in the morning when they get up, and you do some of those tests, and it may or may not mean that they actually have a rheumatological condition.
Yes, that's true. I mean, everyone is different, like how they're present. I mean, unfortunately, like sometimes in looking at some patients, it's more obvious. You can see like the swelling and stuff, and it's obvious on the exam. But in some patients, if they have like the inflammation that is subtle, you might not pick it up on the exam. So then there are other ways to look at it. I mean, like, and if you do like an MRI, which is very sensitive, it picks up like if there is any inflammation around the joint. So in some patients with early rheumatoid arthritis who have symptoms, like especially if they have like pain, if they have like morning stiffness, and you're leaning towards that. If you have like blood tests, you do blood tests and that show like slightly elevated inflammatory markers, suggesting that they probably have some inflammation in the joints. I think there are other ways to diagnose and other ways to get more information.
Yeah.
And that way, I think, I mean, yeah, so in those scenarios, I think like the MRI is helpful. Sometimes you can also do musculoskeletal ultrasound depending on who is doing it, and they can pick up early synovitis on an ultrasound versus doing like an X-ray where you can't really see much unless really it comes to the point where it's destroying the joint. That's the only time you see. So if you see something on an X-ray, it's too late actually.
Mm-hmm. Yeah. Yeah. Okay. Very good. So the next one thing I want to talk about is, I'm guessing, probably the most common type of arthritis, the type that I'm feeling in my neck right now as we're speaking. That is osteoarthritis. So you want to talk a little about exactly what is osteoarthritis, Ajay?
So as you said, yes, it is one of the most common forms of arthritis. And what it basically is it basically is wear and tear of the protective cartilage that you usually have at the ends of the bones, like in the joints, what we call as an articular cartilage, which basically line the margins of the bone. So that's what gives you the cushion to that. And so it's kind of like a wear and tear arthritis, or what we call as a degenerative arthritis, is because in these patients you don't have as much joint cushion, and then there is a slow progressive destruction of this cartilage. And unfortunately, at least with treatment options we have so far, it's mostly an irreversible process. And and again, everyone is varies. I think just because you have arthritis doesn't mean that you're going to be symptomatic. Although, like if you look at the general population, if you look at someone about the age of 65 or 70, close to half the population, or even more than half the population, has this arthritis, osteoarthritis.
Yeah. Yeah. So you kind of touched on treatment options. What are the the main treatment options that you give to patients as they have osteoarthritis?
So you can basically classify it as like two different kinds of options or two different kind of approaches. One is like a pharmacological therapy, and the one is like a non-pharmacological therapy. So the pharmacological therapy, as I mentioned upfront, that unfortunately there is no cure for osteoarthritis. So anything you do, you're basically trying to help with the symptoms, trying to help with maintaining the quality of life, realizing that there is no cure for it, and you're not changing the direction of the arthritis. So the medications wise, you can start even with like the topical agents. You have like something like a Voltaren or the diclofenac gel. You can use like capsaicin, and then you can use like Tylenol, acetaminophen, and then you have like common medications we use a class of medications called as non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, meloxicam, diclofenac. There's a bunch of these medications, but at the same time you need to see which patient qualifies for these medications, and it all depends on what other medical problems do they have. If they have like any heart problems, if they have any kidney disease, some of these medications are not advisable in those patients. And then you also have the option of in certain population of in certain percentage of patients like who have like severe arthritis, and unfortunately you can't do really much. We do use pain medications. The goal of using the pain medications is one is to improve the quality of life, and at the same time trying to minimize the use of it and keeping it to the short term. But the other options are you can try injection therapies depending on which joint it is. So if it is a large joint like a knee, you have like a couple of different options. You can try like various steroid injections that can help you with the pain, that can help you with the inflammation in there. And then you also have the option of using what we call as the viscose supplementation injections, which are basically like thick gel-like injections, similar to what your joint makes. So it helps like lubricate the joints. It can help you with the symptoms. And the other non-pharmacological approaches I was talking to you about is lifestyle changes, either trying to maintain an optimal weight, which is a significant thing, especially if you have arthritis in the weight-bearing joints, like either like the hips, their knees, or the spine. That makes a big difference. And regular exercise, I think, and obviously a healthy diet. I usually tell them any diet that's good for your heart is good for your joints too.
Yeah, and I think I'm heard that you'd think you probably shouldn't exercise. If, let's say you have an arthritic knee, that you should just not put any weight on it and try to avoid activity. Is that accurate?
No, I think no, that's not true. I mean, exercise in general is good for your arthritis, even if you have an arthritic knee. But the interesting thing is like because you have arthritis, you expect some degree of pain depending on the kind of exercise you do. So in general, like if you do like you start out slow and do exercise, it's actually very good for your joints. It helps strengthen the bones, strengthen the ligaments. It gives you more support to the joint. But at the same time, like I mean, injury obviously can increase the risk of osteoarthritis. So if someone plays like a sport, like either like a soccer or football, and if they injure their shoulder or the knee, obviously it increases the risk of developing arthritis in those joints. But in general, exercise itself is good for you. I mean, like say, as you're talking about, like say if you have like arthritis in the knee, yeah, you might not be able to walk as long because you're going to start having the pain. That doesn't mean that you're worsening your arthritis. It just means that with the kind of activity you're doing, you're basically triggering the pain from the arthritis.
One other thing I wanted to ask you, we're kind of getting close on time here, but sometimes folks have mentioned that they'll talk about their X-ray, and their X-ray of their knee looks horrible. And, from their arthritis, and, oh my gosh, I need to do something about that. What kind of is the rule of thumb? Does the degree of abnormality of an X-ray correspond to you should do something in terms of treatment for your knee, whether that's surgical or non-surgical?
Yeah, I think like it's more than one thing you take into consideration when you're looking at different treatment options. So if you're talking about the knee, yes, definitely. Like if the X-ray shows that the patient has severe osteoarthritis, which basically means that you don't have much cartilage left, you have areas of the bone which are completely exposed. But the other thing is like, what is the goal of doing any kind of intervention? So the goal of any kind of treatment is basically to help with patient's symptoms to improve the quality of life. So if a patient walks in with a bad X-ray, but he says like, I'm fine. I don't have much pain. Even if I have a little bit of pain, I can take some Tylenol. I'm fine. I walk okay, and it doesn't affect my quality of life. Then I would say that, yeah, don't do anything. Don't do anything. Just so be it. Yes, you do have bad arthritis, but you can just leave it alone. But at the same time, you have patients. Maybe the X-rays don't look as bad, but it can affect their quality of life. They say like, I can't walk, I can't function. Then in those cases, I think I'll be a little bit more aggressive and try to
Sure.
do some kind of. So I think at the end of the day, I think it pretty much boils down to the patient preference and how the patient feels rather than how the X-rays look.
Yeah, I can still think of a patient who I met when he was probably in his mid 70s, and his X-ray looked horrible, but he continued to play tennis and enjoy it, and not really have a lot of problems with that well into his 90s.
Yes, absolutely. You're right. You're right. I think,
Yeah.
I think unfortunately there is no easy way of predicting who will have more symptoms and who is not going to have more symptoms. I think everyone is different, and some people with severe arthritis, they might not have much pain, they don't have much symptoms, and some people unfortunately have more.
Yeah. All right. One other viewer question: does cracking knuckles cause arthritis?
No, it doesn't. So, like, I mean, that's one of the common things you hear from the patients. Like, they say, like, I hear like this cracking noise when I move a particular joint. So, one of the common reasons what they hear for cracking is basically you have like multiple ligaments, tendons around the joint that can help you with the mobility and stuff. I think majority of the sounds you hear are related to that. Yes, you do hear in a certain percentage of patients who have like severe arthritis where there is not much cartilage left. Yeah, you can hear these creaking sounds and stuff. But in most of the times, the sounds you hear are basically from the movement of the ligaments or either the tendons around the joint. And no, I think the cracking the knuckles is not, unless like you crack it in such a way that you injure the joint, you're not going to get arthritis in that joint.
All right, so whoever sent that out, have fun cracking your knuckles. You're going to be good. So, all right. Hey, Ajay, it's been great having you on. Actually, for the people that are watching us, I had like lupus and psoriatic arthritis and all these other things we just didn't get to. So, maybe sometime here in the future we'll have you back on and try to knock off a few other diagnoses.
Absolutely. It's been a pleasure talking to you, and feel free to see me, and I'll be happy to answer any questions you have. So,
yeah. Dr. Buddaraju, thank you so much. For our viewers, thank you for watching, and share this with your friends so that they get a chance to get some good information from Dr. Buddaraju as well. Until next week, thank you for watching, and we'll see you soon.